Hello, good evening. My topic is patient selection for M-TEER. We have today two options for transcatheter edge-to-edge repair. We have MitraClip devices and PASCAL devices, 4 devices with a MitraClip, and the PASCAL ACE and PASCAL P10 device with PASCAL, and we're also waiting for PASCAL generation 2 devices. Here's a way of how the two devices treat the mitral regurgitation. At the right image, the MitraClip, and at the left, at the right, the PASCAL device, and the left, MitraClip. According to Carpentier, we have 3 types of mitral regurgitation: type 1 with normal leaflet motion, type 2 with excessive leaflet motion, and type 3 with restricted leaflet motion. And we also have the organic or primary mitral regurgitation and secondary mitral regurgitation, the functional MR, that it's mainly associated to severe LV dysfunction, coronary disease or idiopathic myocardial disease, or atrial functional MR. Also, we have the echo criteria. We can also see at the quantitative criteria that the arrow is over 40 square millimeter for the primary mitral MR and maybe over 30 millimeter for secondary MR. That's a difference. And also the regurgitant volume is over 60 ml for primary MR and maybe over 45 ml for secondary MR. I start with secondary MR. We have this vicious cycle of the mitral regurgitation. At first of all, we have the myocardial injury that may cause LV remodeling. This might distract the mitral apparatus with annular dilatation or papillary muscle displacement, and this may even worsen the mitral regurgitation that worsens more the LV remodeling. The guidelines, the European guidelines, give a 2A indication for TEER. For patients not eligible for surgery and fulfilling criteria suggesting an increased chance of responding to treatment. Also, in ACC guidelines, we have a 2A indication for TEERs in patients with an ejection fraction between 20 and 50%, left ventricular end systolic diameter less than 70 millimeter, and pulmonary artery pressure, systolic pressure less than 70 millimeter per mercury. We also have this algorithm. The patient should be at optimal medical therapy, also CRT if needed. This patient should have life expectancy over a year and he doesn't have a coronary artery disease or other disease requiring treatment. And of course, to be appropriate for a valve fulfilling the criteria of TEER in order to proceed to this edge-to-edge repair. So, if a patient is in COAPT like a column, we proceed for M-TEER, or if he is not in COAPT like criteria, we go for either M-TEER with a 2B indication with palliative care or LVAD or transplantation or destination therapy. So, what are these COAPT criteria? We should have a patient with severe secondary MR, heart failure treatment according to guidelines, NIHA class 2, 3, or ambulatory 4, ejection fraction between 20 and 50%, LV systolic diameter less than 70 millimeter, at least 1 heart failure hospitalization or elevated the last year, or elevated BNP levels, and anatomy suitable for M-TEER. The COAPT was a multi-center trial that with patients with heart failure and moderate to severe MR or severe secondary MR that compared MitraClip with optimal medical therapy versus optimal medical therapy alone. We can see this the results, the primary effectiveness with the patients that had the device. This is for heart failure hospitalization or death and heart failure hospitalizations. We had many crossover in the control arm, and here you can see a significant and sustained MR reduction through 5 years with the device, and an improvement in NIHA class through this device. In contrast, we have the mitral FR, a trial with adverse result that showed us different results, we had worse results with the MitraClip and optimal medical therapy versus optimal medical therapy alone. But there is explanation for this, because in mitral FR trial we had less severe MR cases and dilated left ventricle with a bigger left ventricular end diastolic volume. And as you can see at the right column, we have the distribution of MR severity that the co-opt had patients with more severe MR. And we can see in this table here that the MitraClip is useful in mild to moderate severe LV systolic dysfunction, injection fraction between 20% and left ventricular end systolic volume less than 70 millimeter, and moderate to severe MR also. So we have this term, the severe and proportionate MR, that and severe and disproportionate MR, because at this case the MR is the main problem and not the heart failure. The co-op trial is at the side where the left end diastolic volume is lower and the arrow is bigger, so we had better results there than the mitral FR. What's happening in the real world? About 65% of patients fulfill the co-opt criteria, and which are the absence of severe left ventricular impairment, absence of right ventricular impairment and severe pulmonary hypertension, and absence of hemodynamic instability. And we can see better result at this patient regarding the heart failure, hospitalizations, or death. MitraClip could be used as a bridge to heart transplant, could be used as in acute heart failure. Here is a patient who after at acute pulmonary edema after delayed presentation with anterior myocardial infarction that the MitraClip was used. MitraClip can be, the device in general can be used in decompensated heart failure with a severely functional MR and ejection fraction very low, of 14 at this case. We also have the MiCLASP trial that showed a significant reduction in heart failure hospitalizations sustained 2 years with the PASCAL device in FMR and in DMR. We have significant sustained MR reduction, as you can see there, and improvement in NIHA class at 2 years, and the quality of life also. We have the CLASP 2D trial that evaluated the safety and effectiveness of PASCAL and the MitraClip. We had very good results with those two devices in DMR and in FMR, in DMR, and we wait the CLASP 2F trial also. But after the patient is a co-opt-like patient, we have to check the anatomical suitability for M-TEER. The ideal patient is a patient that has a central pathology, no calcification, with an MVA more than 4 square centimeter, posterior leaflet more than 10 millimeter, tending height less than 10 millimeter, small flail gap and flail width. And we had very good results at these patients. Here you can see an example of a localized posterior P2 flail leaflet. We have more complex cases, like I can show you some examples, like a white P2 flail leaflet that was treated with a PASCAL. Here a white flail A2 leaflet with a large gap that was treated with two PASCAL devices, and a very good result. Here a P3 commissural prolapse that was treated with a XCW MitraClip device. And also we have very complex cases like calcified annulus, leaflet, subvalvular apparatus. Here we have a P1 flail that was treated with a PASCAL ACE device. Calcified A1 and A2 leaflet flail that was treated also with PASCAL ACE device. And here we had a screening failure for TEER because of the very short posterior leaflet. Regarding primary MR, here the surgery has a class 1 indication when the results are expected to be durable. The TEER has a 2B indication when the patient is inoperable or at high surgical risk by the heart team. And this is also the algorithm at the primary MR. In the HC guidelines, TEER has a 2A indication for the primary MR. And I will show you a quick example of a patient treated with a central MR, treated with PASCAL device. Here we had an injection fraction of 40%, a dilated left ventricle, a large central jet from this device, dilated annulus, mitral valve from the 3D echo decoder, and no calcification there with a great opening of the valve. Vena contracta width of 16 millimeter. Here is a transeptal height and entry in the left atrium. Here we can see our device in the left atrium. And just above the mitral valve, we do the perpendicularity testing, and after that we close our device. We had a mild regurgitation jet or moderate from the medial part of the valve, so we decided to optimize our posterior leaflet. And here we finish with an excellent result for the mitral valve. We do our M-TEER checking, and the 3D echo here gives us an excellent result. So in summary, TEER is expanding rapidly for patients with degenerative MR at high surgical risk or for patients with FMR as a first approach unless other surgical indication. TEER for efficiency and safety is the dominant modality. However, of course, not all patients are anatomically suitable, and other therapies are emerging. Transcatheter therapies are promising to fill the gap. As we heard before, the M3 has already will follow. So thank you very much.
Excellent. So any comments on Dr. Kotroulou? Are you happy with the imaging? This is amazing imaging, and congratulations to the Hygeia team for this excellent imaging.
It's actually amazing. I was really amazed from not from the easy ones that you showed us at the end, Dr. Aravantinos, but at the very, very complicated cases that you made it, cases that probably someone would see with the TOE and would say that it's not doable to be done. But it seems like Dr. Sparias can do anything that we ask for. I totally agree with all the things that you presented. It was a really very nice presentation about what we have to look for before we send the patient for MitraClip. I have actually a question for Dr. Sparias, if it's okay. Left atrial volume, more than 60, we all know that it's considered to be a big left atrium. And yes, we look at the flail gap, we look at the flail width so as to be sure that you're going to be able to be able to have the mitral clip in place. It's very important actually for the clinical cardiologist to continue the medical management for those patients, because you may be able to reduce the MR or the TR for the tricuspid valve, but if this patient does not use diuretics at home, this regurgitation may get worse. And my question for you, Dr. Sparias, is if the left atrium is really a big left atrium, you still have the gap and the width measurement on your TOE, and you can supposedly place the mitral clip. Based on your experience, is there a patient population that the clip fails down the road after like a few months if the left atrium is very big? And do you feel that maybe in the literature in the future a lot of research is going to be done about having issues with very big mitral annulus?
That's a very interesting question. So if you're referring to atrial functional MR with only the left atrium dilated, but with normal left ventricle, these cases, I would say technically they're relatively easy for us, as it's easy for you, Apostolos, because we go with one device. Usually if we go with PASCAL, we use the one with a spacer, and we are successful. Now, if you consider that the left atrial enlargement is an indicator of a more advanced disease, which I think it is, then that's why we're not sure about the long-term results of clipping atrial FMRs. I don't know if I cover with my answer.
Think so.
Yeah.
I think so. What I think it's very important for you also, I believe, it's not only the 2 years, but also the down the road, because it seems like you are treating the patient, so they're going to live for a few years So what I'm trying to figure out is if there is more criteria to correctly identify which patients are gonna get better results for like 5, 6, 7 years or so.
You're right. I think atrial enlargement is just an indicator, a bad prognosticator. It means there is an underlying pathology that is going on for a long time, like atrial fibrillation. And if it's dilated, then you cannot do like ablation together. That would be another option. But in a dilated atrium, it's not going to work. So in these patients, I think medical therapy is very important. And clipping comes as an supportive interventional therapy that will certainly improve some symptoms, but we don't really know in atrial FMR the long-term results, like I said in earlier presentations.
One more question. What about annuloplasty via, I know that this happened in the future, the results were not as good, but what about as the technology goes on, as far as you know, Dr. Spargas, because I know that you know everything that is, do you see anything coming in the future? Because I think it's a key for those patients, having clip but also annuloplasty.
Yeah. We have an annuloplasty option, Tzikas option, that is CE-marked, the Cardioband. But I don't think its penetration has been so successful because it's been on with CE-mark like for almost 10 years now. But I doubt if there have been more than 1,000 commercial implantations. It seems that it's more successful in the tricuspid area. So it's mostly used in the Cardioband in tricuspid. But there are many other technologies that are doing transcatheter annuloplasty that are in development. And we have seen in the big meetings presentations of this. I don't know if some of them will be successful in the future. I guess it will. One of them, Cardioband, also has another generation that it comes now, the Cardioband Fit, simpler. I think it's, you have for a transcatheter therapy to be successful, it has to be easy, user-friendly, and quick. If it is something that is complex, it takes time, and it's not user-friendly, then even if it's successful, it's not going to have the huge penetration. So we'll see in the future. If a transcatheter annuloplasty will come into place. Now the Carilion, which is the annuloplasty, the indirect annuloplasty through the coronary sinus, is another option, and there is a big study that is going on with the Carilion. The problem with the indirect annuloplasty is that we know from the studies that anatomically the plane of the mitral annulus and the plane of the coronary sinus, they're not very close in reality. So any effect, it's not big, and I don't know if it will be measurable in clinical terms. And the other problem with indirect annuloplasty is that you have the circumflex artery in a large proportion of patients underneath you. So if you cinch very tightly, then you create a problem in the circumflex. And that's why I heard that this study, the Empire study, the endpoint changed from MR reduction to left ventricle remodeling.
Good. So this explains all. Dr. Belagi, any comment?
I have a question as well. It's difficult to look into the future, but is there... I think when we talk about expanding the indications for patients that undergo transcatheter treatments on the mitral valve, I think what seems to me obvious is that probably transcatheter mitral valve repair with tears or clips might be actually replaced by replacements. Because if replacements become very easily done, and as you said, something easy and fast and reliable, then we might actually be able to implement transcatheter valve replacements on more patients compared to the ones we have the clips. So we have, let's say, easier and better sealing and better reduction in the MR in the future. So I don't know whether you see the clip in the next maybe 10 years, I don't know, not being used as it's used now. as an interim, let's say, device until we have very good transcatheter mitral valve replacements?
Fortunately for clips, I think their future is still bright. I'm not very optimistic about TMVR that will come and replace the clips. I think mitral valve is so complex and it doesn't forgive any mistakes with valves. That's why it's been so long to have one valve in the market. On the other hand, a tricuspid valve, I think it's easier because of the lower pressures. And the proof is that although it's been tested for so short time compared to the mitral valve, we already have a tricuspid valve available, transcatheter, and we have a second one soon. So I think clipping will remain the mainstay because the devices, the prostheses are smaller compared to the valves, and they usually, they don't degenerate like the valves. The valves will degenerate and we'll need another valve in the future.
Good, so we have to leave it there. So thank you, Dr. Aravantinos. So the next speaker is Dr. Drakopoulou.